Good evening, everyone. The meeting is live now. Welcome to everyone to this 47th chapter in the third series of masterclasses brought to you by the Academic Council of Indian Association of Surgical Oncology. The topic for today is parathyroid tumors. I invite IASO President, Professor P.K. Das, to kindly open the session for today. Sir.
Thank you, Susan. Respected IASO members, respected all the past president and as well as the journal advisors, respected the convener, Dr. Subramanieswar Rao, Dr. Srijan, and all the audience. So this is our flagship program of IASO academics, the IASO Masterclass, which has gained popularity over the last 2 years, and this is the third year we are running this program. So every second Tuesday we are running this program. So almost 20 to 24 series in a year. And last program was on the adrenal tumor. So we thought parathyroid tumor would be the really suiting to this program, because any neck, anterior part of the any swelling in the anterior part of the neck, parathyroid tumor comes to the differential diagnosis as well. And this is not very, very rare tumor, so the examiners also should have a good knowledge on clinical examination and face the examiners. So with these few words, I introduce Dr. Mani Abraham Curious from Kochi, and I also welcome sir for this masterclass, and also Dr. Amit Agarwal from Lucknow. I welcome you, Dr. Amit. So with these few words, I must hand over the mic to Dr. Subramanieswar.
Thank you, sir.
I invite Dr. T.S. Rao to kindly introduce our faculty for today.
Both the faculty, I think, are extremely popular among students and the younger colleagues in the profession. Mani Abraham Kuriakose is a very renowned teacher and a scientist. He served as the medical director and he was the co-founder and the CEO of Kerala operations of Kakinos Healthcare, Mumbai at present. He was a professor and vice chairman, Department of Head, Neck, and Reconstructive Surgery, Rothal Park Cancer Institute. He extended his services in multiple organizations and actually developed head and neck across the country and elsewhere. He worked in Amrita Institute, Narayana Hrudayalaya, and various other institutes, and he has been largely responsible for inspiring and influencing development of head neck surgery in this country. Very dedicated teacher and an extremely talented surgeon. Welcome, Dr. Mani Abraham Kuriakose.
Thank you, sir.
Amit Agarwal is another renowned teacher, somebody who has held on to a central institute, and he has been serving the institute for a long time. Now is the director of breast and endocrine surgery at the Medanta Hospital in Lucknow. Formerly, he was a professor and head of endocrine surgery, breast and endocrine services at the Sanjay Gandhi Institute of Medical Sciences. And then his special interest is in robotic surgery, parathyroid surgery, and breast oncoplasty. He has more than 200 publications. He has published 6 books and hundreds of lectures across the world. He's been the past president of Indian Thyroid Society and Endocrine Society. He's a council member of International Association of Endocrine Surgeons, Asian Association of Endocrine Surgeons, Asia Pacific Society of Thyroid Surgeons, Indian Society of Thyroid Surgeons, and various other organizations. He is also the editor-in-chief of World Journal of Endocrine Surgery. We always wanted Amit to be a part of IASO, So we are glad that he consented to teach our students and the young faculty. Welcome to IASO academics, both of you gentlemen. I'm sure this session will go seamlessly because of the scholarship that you are known for, and the teaching abilities that you are very popularly known for. So please take over the session, and I thank you for your presence here.
Thank you, sir. The examinees for today are Dr. Gina Josephine, who's a resident in the Department of Surgical Oncology at All India Institute of Medical Sciences, New Delhi, and Dr. Samarth Dave, who's a resident in the Department of Surgical Oncology at Mahatma Gandhi Medical College, Jaipur. A few instructions for the session. The first 1 hour will be a mock examination. To our moderator, Dr. Moni Ibrahim, we request you to please address the examinee by their name, Dr. Gina and Dr. Samarth, to avoid any confusion as to who's supposed to answer a particular question, and to ensure that both of them get equal opportunities to participate. For our examiner and the moderator, both in interest of online viewers, both who are online today as well as future viewers who are viewing this on YouTube, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered. In this one area, this would be different from an actual exam. To our examinees, Dr. Gina and Dr. Samarth, kindly give to-the-point answers. No one is expected to know everything. So if you don't know something, just pass it along. It saves us time and maintains the flow of this webinar pattern. And it's up to you to catch the hints that hopefully our examiners will be throwing down your way. For our participants, we see some few very senior IASO members. We thank you for logging in, and we highly appreciate your inputs in the chat box as well. For the residents, this is an amazing opportunity to clear all your doubts on this subject. I'll be maintaining the time, and at 30 minutes, 45 minutes, and then at the conclusion, 60 minutes, I'll be giving a ping to the moderator over the chat box. Over to our moderator, Dr. Moni Ibrahim. Sir, you might share your screen, and please take over.
Thank you so much, Dr. Rao. Thank you very much for the kind words. I hope you can see my slide as well as you can hear me.
Yes, sir. Perfect.
You can see the slide, and Samarth, you can see the slide. Okay, very good. Excellent. So I will have 2 cases to discuss. So I have 2 cases to discuss. So if you all can mute, and then only Gina and Samarth can unmute and speak. Okay. Our first patient we need to discuss is a 46-year-old homemaker, and she had a routine health checkup, annual health checkup, no prior symptoms or no other health problems. And the routine health checkup showed a calcium value of 10.9. Just to remind all of us, the normal value is 8.5 to 10.5. Okay. And medical history wise, she is hypothyroid, and she's taking Thyronorm, and also history of diabetes mellitus. Okay, well controlled. My first question to Gina, Dr. Gina, how will you evaluate this patient?
In this patient, serum calcium is mildly elevated, and I need to know serum albumin level and ionized calcium level.
Okay, what do you know? Why do you want to know the albumin level?
Albumin level is to know for the corrected calcium level. This is a total calcium level 10.1. Based on the albumin, it changes. So we need to know the corrected calcium level.
Okay, Dr. Samarth, how do you estimate the corrected calcium? Dr. Samarth, you can hear me? Dr. Samarth? I think we have a bit of a problem. Can you unmute and speak, Dr. Samarth? Okay. I think probably Dr. Gina, you are the only person then I need to discuss. Okay. Then how will you evaluate this patient?
Corrected calcium.
Let's assume that the albumin is normal and the corrected calcium is around 10 point, same number.
The corrected calcium level will be the measured calcium plus 0.8 into 4 minus the serum albumin. And four is the median cutoff we are taking for the serum normal albumin range, and 0.8 we are taking because studies have shown that every 0.8 degrees in for every 1 gram of albumin, there will be fall in 0.8 milligrams of calcium. So we have calculated to know the corrected calcium level from this formula.
Okay, so let's assume that patient has a borderline elevated calcium. How will you evaluate?
Now this patient, next step will be we have to measure the serum parathormone level.
Okay, let's see what the result we have. Okay, so patient had, we have the history. Let's say that anything else you take in the history?
In the history, we have to ask the symptoms of hypercalcemia, renal symptoms, such as patient is having polyuria, polydipsia, renal colic. For bone symptoms such as bone pain, and muscle weakness, easy fatigability, depression, confusion. All these symptoms we can ask to find out whether the patient is having a symptom of hypercalcemia.
So what are the end organs which can be affected by increased calcium? So you mentioned about the bone, you mentioned about
kidney, GIT,
then
pancreas.
Pancreas.
Sir, am I audible, sir?
Yes, Dr. Samar, yes, you're back.
Dr. Gina. Yeah, Dr. Gina.
Yes, sir.
Anything particular about fractures? Anything special about fractures you would ask?
There will be fragility fractures or pathological fractures because of trivial trauma.
Yeah, so can you define what is trivial trauma?
When there is not the impact of trauma may not be more. Trivial trauma is patient will have fracture when the patient hits somewhere. It is not a significant.
Sir, am I audible, sir?
Yes, Samat, you can hear you now.
Yes, sir.
If the bandwidth is an issue, you can switch off the video, but right now you can see it. Okay, very good. Let's go to the next one. And then investigation based on the history we need to take up. And then what is at the end of the evaluation, what do you need to decide? Samat, if you can answer the questions. Let's say you have done the history, clinical evaluation, and Dr. Gina want to do the PTH assay, but the end of it, what do you want to get out of it?
Sir, after completion of physical history and physical examination, as you have already provided the serum calcium level, I need to see the corrected calcium level depending upon the levels. After that, PTH level, and again for serum phosphate levels. Then I also need to see the vitamin D3 levels in the blood, and RFT also I need to check, sir.
Okay, so essentially what we are trying to do, we're trying to find out a patient with a hypercalcemia with a normal hormone or a hypercalcemia with a hyper-elevated PTH, is that right? These are the two broad categories we need to stratify, okay? And let's come to this patient. And the symptoms-wise, we had I think Gina mentioned most of the questions, and other symptoms, other signs and symptoms I've just mentioned there, okay? And the association with the men type 1 and 2, Samarth, if you can just to highlight on that, how will you identify them and evaluate?
Sir, familial hyperparathyroidism usually is seen in MEN 1 and MEN 2A syndromes. MEN 1 syndrome usually have 3 Ps like parathyroid, pituitary adenoma, and pancreatic neuroendocrine tumors. And along with that, they can have bronchus and thymic carcinoid also. And MEN 2A syndrome usually have, they are also called as sickle syndrome, and they are usually have medullary carcinoma, thyroid pheochromocytoma, and parathyroid adenoma as well as hyperplasia also. Usually, sir, these familial syndromes would be having higher chances of 4-gland disease. Most commonly
No,
seen
can I
in
interrupt you, Samath? Yeah, can I interrupt you? When you suspect there is a related so hypercalcemia, what are the pointers towards
Sir,
when did you suspect?
sir, I could not hear you.
Dr. Amit, the sound is breaking, Dr. Amit.
Yeah.
Sir, it would help if you can stop your video. I think it'll help with your bandwidth.
Dr. Amit, if you can just repeat the question. Okay, let's, Dr. Amit will come back to us. Okay. So what's the differential diagnosis in this situation? Let's say that patient with, you have taken a patient with the patient we presented. What are the possibility of the elevated calcium? I just made that, yeah.
Sir, possible causes for hypercalcemia can be, sir, parathyroid related and non-parathyroid related. Parathyroid causes will be parathyroid hyperplasia and adenoma. Parathyroid carcinoma can also have hypercalcemia. And among non-parathyroid causes, there are multiple headings like endocrine causes, malignant causes, then granulomatous diseases, and medications and other causes. Among endocrine causes, usually will have thyrotoxicosis or adrenal insufficiency. For malignancy, most commonly the solid tumors like breast, lung will have hypercalcemia, and osteolytic bone lesions, and also hematological malignancies like lymphoma and non-Hodgkin's lymphoma, multiple myeloma will be having hypercalcemia. Among the granulomatous causes, there will be a history of sarcoidosis, tuberculosis, and the medical causes will be any history of taking lithium, thiazide diuretics, and vitamin D3 supplementation can also be causes of hypercalcemia, sir.
Okay. Dr. Amit, you're back. Okay. So let's say that we have come to our patient now, the patient with hypercalcemia. Okay. And the investigations, so Dr. Samath, if you can continue, what are the tests? You mentioned some of them, but if you can just complete the investigation, that'll be good.
Sir, along with the routine blood and biochemistry investigations, I would like to specifically for the disease, I would like to see total albumin levels, phosphate levels, RFT, and vitamin D3 levels. And alkaline phosphatase levels also, because if there is a higher bone turnover rate, alkaline phosphate can also be increased, sir.
Okay. Gina, what's the importance of vitamin D3 measurement?
So vitamin D3, if it is low, then it is one of the cause of secondary hyperparathyroidism.
Anything else? What's the association of symptoms of hypercalcemia and vitamin D3? Any correlation?
Vitamin D3 increases calcium absorption in the intestine.
Samarth, anything you want to add?
Sir, vitamin D3 usually acts on at 3 areas: renal, GI, and this bone level. So, if there is any malabsorption, in the case of vitamin D3 levels high, there will be osteoclastic activity increasing, bone disruption will be more, sir.
Okay. So let's come back to our patient now. The calcium is 10.9. Additional investigation we mentioned. The PTH is 300. Clearly is elevated. Okay. And D3 is 34 within the normal limit. Okay. Renal function test and or within the normal limit. Okay. 24-hour urine was carried out. Okay. That was within normal limit. And the calcitonin and serum metanephrine was carried out. What's the need for that, Samath?
Sir, calcitonin and serum metanephrine levels will help in ruling out other MEN2 syndromes like in medullary carcinoma, thyroid calcitonin will be increased, and in pheochromocytoma also we need to rule out these familial causes. So we need to do these lab tests.
Okay. Dr. Amit, I think you're back now.
Yeah. So can I ask Dr. Samath, what is the need for doing a 24-hour urinary calcium?
Sir, if there is hypercalcemia, we need to see whether it is a hypocalciuric hypercalcemia or hypercalciuric hypercalcemia. So when we do a 24-hour urinary calcium level, and it is also one of the criteria for deciding whether an asymptomatic patient needs a surgical intervention or not. So if it is more than 400 milligram in 24 hours, then we can decide whether this patient needs surgical intervention or not. So in this way, it will help us in deciding the future.
And more importantly is what to DIFHH, which is
Sir, familial hypercalcemic hypocalciuria.
disease.
Dr. Amit, I think we just lost you.
Serum calcium is normal. What?
So sorry, sir.
Hello.
Dr. Amit, we just lost you.
Normal. The test you'd like to do.
Okay. I think we'll come back to. So, okay, I just want to, for your reference, there's a very good article about indication of parathyroid surgery. And let me get to Dr. Gina. Okay. So when will you, I think Dr. Amit was asking about the indication. When do you intervene for a surgery when a particular patient? What's the indication to do surgery?
When the patient is having symptoms of fractures or renal nephrocalcinosis or nephrolithiasis, or when the age of the patient is less than 50 years of age, or when the serum calcium level is more than 1 gram above the upper limit. These are the indications of thyroid surgery.
Samath, you want to add anything?
Yes, sir. Renal indication will be, sir, EGFR rate less than 60, and serum calcium level more than 1 milligram per deciliter above normal, age less than 50 years. Then any history of nephrocalcinosis.
Anything more than what is already in
Yes, sir. Yes, sir. Decreased bone mineral density, T-score less than 2.5 in the distal radius or hip or vertebra. And any patient who is not a candidate for a follow-up, then we can do for surgical intervention.
And what will you do for this patient? This patient I presented.
Sir, for this patient, as we have confirmed the biochemical diagnosis, we need to do the imaging of the.
Well, will you recommend surgery or not for this patient?
Sir, can I again ask the age of the patient?
Age is 46.
Yes, sir. Age of the patient is less than 50 years because, sir, studies have shown that when the patient's age is younger, there are higher chances of hyperparathyroidism related complication because
so you mentioned that. So will you recommend surgery or not? This is your patient in front of you.
Yes, sir.
Okay, Gina, what do you think?
Yes, sir, we have to go for surgery in this patient. Since parathyroid level is high and patient's age is less than 50 years, serum calcium is not elevated more than 1 gram above the upper limit, but parathyroid is elevated and age is the criteria.
Age is because age we'll have to. So this is the indication. Okay. Did we miss anything? I think looks like we covered everything. Okay. Good. Investigation wise, I listed them here. Okay. Can you, I think, Gina, can you tell me the merits and demerits of each of the tests?
Ultrasound next should be the initial evaluation for suspecting parathyroid lesion. It shows from this ultrasound neck, we know the heterogeneous nature of the lesion, irregularity of the margins, and bigger size lesion can be seen. The demerit will be differentiating between the thyroid nodule and the parathyroid may be difficult in ultrasound.
And Samarth, if we can ask, is any places where we can have difficulty with ultrasound?
Sir, ultrasound, as a principle of ultrasound is depending upon the ultrasound waves. When there will be bone in between, it will be difficult. So any ectopic sites of parathyroid where in mediastinum will be having difficulties.
Any other problems? Any other locations will have problem?
In mediastinum, retroesophageal, paravertebral.
Okay, very good. Okay, excellent. Okay, then you mentioned about the parathyroid, but thyroid also we evaluate, is that right?
Yes, sir.
Intrathyroidal abnormalities and the lymph nodes also we evaluate. Okay, let's get Gina to speak about the nuclear imaging system EB scan.
System EB scan, it is system EB is the methoxy isobutyl isonitrile. It is combined with the 99 technetium. This shows in this we have two phases. We can do dual phase technique or a subtraction phase technique in system EB scan. In the dual phase technique, we have to take the images at different point of time. Initially 15 minutes and delayed images 1 hour and after 2 to 3 hours. This is to pick up the parathyroid lesion, because thyroid also take up the system maybe initially, but there will be washout in the delayed images, so that parathyroid is clearly seen in the system maybe. When there is a difficulty in differentiating between the thyroid and the parathyroid lesion, then we can go for the subtraction images. There we have to use both technetium and also iodine 123. Technetium will be taken only by the parathyroid, but iodine 123 and technetium both will be taken by the thyroid. We can subtract the thyroid part and we can find out the parathyroid lesion in the subtraction phase.
And Samarth,
Dr. Gina.
Yeah, go ahead, sir. Yeah.
Yeah. Can you hear me now?
Yes, sir.
I hope I'm clear now.
Yeah, we can.
So, Dr. Gina,
Yes,
my question is, why do you need these localizing studies? Would you do in all patients? Why do you want to do this?
Only when we plan for surgery in parathyroid lesions, then we have to go for localizing, preoperative localization. That is to prevent the extensive bilateral neck exploration, to go for minimally invasive parathyroidectomy.
So only when you are planning a focus for a minimally invasive, you would like to localize. Otherwise you
not
do a bilateral exploration. Yeah.
No, not
so Dr. Samarth, we have done an ultrasound, we have done a nuclear scan. What do you interpret on these two things? Why do you want to do both?
Yes, sir. Sir, we need to do both because ultrasonography is has some limitations because of the investigation. Like it is operator dependent, and the findings are important when usually more important when it is done by any experienced hand, and also it is also subjective. So we need to.
No, I think just to for the sake of time, you need one anatomical investigation and one functional. So ultrasound is anatomical investigation and nuclear scan is functional. Dr.
Yes.
Gina, what do you mean by a concordant imaging and what do you mean by a discordant imaging?
When the ultrasound neck finding and also the system EB scan findings are both are same, like when it is localizing a single gland pointing towards one gland, then it is a concordant imaging.
No, so suppose the ultrasound says right superior and the scan tells you left inferior. Do you think that is concordant? Both are showing single image.
No, sir. It is not when the ultrasound next showing superior and system maybe also shows the superior gland, then it is a concordant image.
So same. So it's not only the number; it's the three things: same side, same side, and same number.
Yes.
Then it is known as concordant. So you're looking for a concordant.
Yes.
Dr. Moni, you can proceed, please.
Thank you. And then Samath, role of cross-sectional images. When will you do that? CT or MRI scan?
Sir, ultrasonography and radionuclide will have a functional and anatomical imaging, but cross-sectional imaging will have a better spatial configuration of the tumor, and better localization of the tumor will be spatial anatomical diagnosis will be better with this cross-sectional imaging, sir.
So will you do for all the patients, all the three modalities?
No, sir. Ultrasound and radionuclide scans are the initial investigation of choice. When there is discordant findings on the both imaging, then usually a 4D CT scan is a preferred modality of choice for further criteria.
Gina, tell us about this. What is this 4D CT scan?
4D CT scan, in 3D images, we can see the three-dimensional volume of the gland, and we can slice it and see a three-dimensional volume. And the fourth dimension is the motion and the time of the CT.
Okay, at the end of
The
it.
disadvantage of 4D CT. What is the advantage of 4D CT?
Advantages of 4D CT is we can find out the ectopic.
Disadvantage. Can you hear me, Dr. Jin?
Yes.
And also, what is the disadvantage of 4D CT scan?
Dr. Gina, disadvantage of 4D CT scan. Okay, Dr. Samath?
Yes, sir. Sir, cost availability will be and high radiation dose will be given in 4D CT scans.
Correct. So suppose the all the three modalities are negative, but you have a confirmed biochemical diagnosis. Is there anything else you can use for localization?
Yes, sir. If we are still suspecting that there is a parathyroid tumor, then newer techniques like F18 choline PET CT scan and C11 methionine PET CT scan are also important to localize the parathyroid tumors. They are the newer modalities.
Good, correct. Yes.
Okay.
Dr. Moni, we can move forward.
Thank you. Thank you, sir. So at the end of it, we need to know whether inferior, superior, anterior, posterior, and ectopic. Okay. Let's look at this patient. Okay. So this is our patient. Patient had the ultrasound first. Okay. I'll just tell you what the findings which was reported by our ultrasonographer. There was a right inferior lesion measuring about 14.3 by 12.7 by 6.4. And thyroid essentially was normal, and which is localized here. Okay, and I think we have pointed out the issues and benefits and drawbacks. Okay, and patient also had a sesame B scan. Let me just move this image there. Okay, and that also confirmed a more than 1.8 centimeter right inferior parathyroid. Okay, so what kind of conclusion you'll make, Dr. Samath?
Sir, depending upon these two findings, there is a solitary parathyroid adenoma in the right inferior parathyroid gland.
Okay, good. For the anatomy purpose, probably one can do a SPECT maybe scan in a combination so that you can anatomically locate. Okay, so how will you approach this lesion, Gina?
So we can go for a minimal invasive parathyroidectomy in this patient.
Mm-hmm.
It can be a video assisted or endoscopic parathyroidectomy, or a minimal incision less than 3 centimeter, a transverse incision. It may be a central incision or a lateral incision.
What's the benefit one over the other? Or what will you choose, by the way?
Yeah, we can go for an endoscopic parathyroidectomy.
What's your choice? What's your preferred method of, let's say, if you're going to do it, how will you do it?
Go for a minimal invasive parathyroidectomy by putting a small incision less than 3 centimeter.
Where do you do that? You said midline as well as lateral, is that right? What's the advantage? What will you do? What is your choice of approach?
Here, the lesion is clear cut in the inferior pole of the right side. We can go for a lateral small incision.
Okay. Samarth, you agree?
Yes, sir.
Okay, good. Okay, I'll just put some of the criteria. So what are the other things you will need, armamentarium you need if you were to go for a minimally invasive parathyroidectomy? Samarth?
Yes, sir.
Let's say you're going to go for a minimally invasive parathyroid surgery by a lateral or midline approach, whichever you like. Okay. What are the other adjuncts you will ask for during the surgery?
So for adjunct for confirmation that we are in parathyroid tumor or not, intraoperative parathyroid hormone level will be better for diagnosis. So first, they are usually taken pre-incision and pre-excision. So these two findings are taken before removing the tumor. And after these are the baseline PTH levels. And after incision, after excision of the tumor, the parathyroid, the blood samples are taken at T0, T5, and T10 minutes. When these usually mainly depend on the Miami criteria, which showed that more than 50% decrease or parathyroid level when they come to normal range. Then after 10 minutes, then it is the operational success rate that it is parathyroid tumor we have removed.
Okay. Gina, anything else you will use as adjunct?
We have to be careful about the recurrent laryngeal now to prevent injury to the lesion. We can identify the recurrent laryngeal now based on the anatomical landmark. We can also use intraoperative nerve monitoring. Okay,
that's another thing which can do. Anything else you need?
We can use a gamma probe also. For preoperatively, we have to give 10 to 20 millicurie of technetium-99, and then after removal of the tumor, we have to see the activity with the help of gamma probe, and that is also adjunct that confirmation that we will remove or not.
Okay. Anything else you do, Gina?
Since the lesion is since the both ultrasound and system we showed a single lesion, intraoperative ultrasound may not be needed. Otherwise, we can go for intraoperative ultrasound and methylene blue dye injection to localize the other parathyroid glands.
Okay. How about frozen section?
Frozen section, it will not differentiate between a benign and the malignant tumor.
Any other use you will have? What other structures you need to differentiate during the procedure? Most common things.
From the fat and the parathyroid tissue, and also whether it to prevent thyroid tissue and also the parathyroid tissue.
Samarth?
We have to differentiate from a lymph node also, because most commonly we can confuse it with the lymph node also. So along with we have to differentiate it from the lymph nodes.
Okay. Dr. Amit, any questions to us?
Yeah, so a couple of questions. How would you decide where to place the incision? Dr. Gina?
So in case of palpable lesions, we have to go for a low collar transverse skin crease incision.
So actually the best is to do a surgeon performed ultrasound. It's good to do a ultrasound in the theater. It helps you to place the incision. So for the focused parathyroidectomy or a minimal invasive, what are the components? When would you call your procedure a focused parathyroidectomy or a minimally invasive parathyroidectomy?
When we are focusing on one gland and we are not exploring the other glands, then it is a focused parathyroidectomy. If we are exploring
the other glands means even the ipsilateral gland, you don't make an attempt to see. Leave aside the opposite.
Then it will be unilateral neck exploration if we are explore both the glands.
So just for the benefit of those guys, so it's a small incision, minimal dissection, and no attempt to see the ipsilateral parathyroid gland with or without intraoperative PTH. So these are the three components of a focused or a minimally invasive parathyroidectomy.
Okay, let's go to the.
Okay. Yeah.
So this we covered. Okay, depending on the comfort level, whether intraoperative nerve monitoring required, gamma probe requirement, but definitely we need to have the PTH, rapid PTH will be of use. Okay, good. And monitoring, the gamma radioid guided surgery, that is, so this is surgery at the time of, just to want to orient here. And this is a chin of the patient, clavicle here. This is a right thyroid lobe and the parathyroid here. What kind of approach is that? Samarth, where was incision placed here for the patient?
So the incision is placed in the midline, 2 centimeter or 2 finger width above the suprasternal notch.
Yeah. Okay. So as Dr. Gina was mentioning, another approach is lateral. And if you're going to do lateral approach, how will you access this lesion? What's the plane in which you access this tumor?
So for lateral approach, after giving incision and raising the flap, we have to go in between the strap muscles and sternocleidomastoid muscle. So sternocleidomastoid muscle is retracted lateral and strap muscles medial. So we can have a better access in the tracheoesophageal groove and.
Okay, where will be the recurrent laryngeal nerve for this patient in relation to the parathyroid?
So usually inferior parathyroid glands are anterior to recurrent laryngeal nerve. So, and usually they are at the inferior pole of thyroid gland, near the inferior pole of thyroid gland, anterior to the nerve. Sir.
Okay, anterior to the nerve, and mediolaterally?
Sorry, sir?
Mediolaterally, where will be the?
Mediolaterally, sir, will be lateral to the.
Gina?
Anterolaterally, sir.
Okay. So just the same patient here. Okay, chin of the patient is there, neck, clavicle here, gland here, and the parathyroid here. Okay. And then measured that 1.8. At start, the PTH is 265 and 10 minutes 60. Are you happy with it?
Yes.
Samarth?
Yes, sir.
We can stop it. Is that right? Okay, good.
Yes, sir.
Post-operative, how will you manage? Post-operative management of this patient.
So post-operative management, as we have only removed one parathyroid gland, usually there is a good post-operative recovery and nothing much to be done. Apart from routine post-operative complication which can occur like hematoma or possible injury to ipsilateral recurrent laryngeal nerve.
Gina, anything else you watch out for this patient?
In initial post-op period, we have to look for the bone syndrome, sir, because initially the parathormone level is high, but usually that get manifested when there will be vitamin deficiency, D deficiency. In this patient, vitamin D level is low, normal, so we are not expecting bone syndrome in this patient.
Okay. Good. And then when will you check for the multiple glands? Maybe Gina, why don't you take it up?
So we have to check calcium
Not
and
this patient. Yeah, not this patient. You're here, you're going to focus the parathyroidectomy, but when will you think about doing multiple gland excision?
we have to check the post-operative parathormone and the calcium level. When it is high, if it is high within 6 months of the surgery, then there will be a persistent hyperparathyroidism. When we find out more than when the parathormone becomes normal within 6 months, and after that, if it increases more than 6 to 12 months, then it will be a recurrent hyperparathyroidism.
Okay. In the primary setting, before you start the surgery, like when a patient coming with, you plan for multiple gland exploratory surgery, when will you do that?
In case of parathyroid hyperplasia,
How will you evaluate? How will you diagnose that?
so we have to go for the two modalities, ultrasound neck and sestamibi scan, to look for the parathyroid hyperplasia. Whether all the 4 glands are whether how many glands are involved. And in case of second parathyroid hyperplasia, the hyperparathyroidism may not be that much high when compared to the primary, when compared to the parathyroid adenoma or parathyroid carcinoma.
Okay. All right. Okay. Let me just go through that. So this particular patient, the pathology was the 550 milligram was the size of the lesion, the normal size I've mentioned there, and the diagnosis was parathyroid adenoma. Okay. And I just want to go to another area, normal hormone primary hyperparathyroidism. So I just mentioned here, let's skip this, but just keep it in your back of the mind so that this can be, you can cover that, you can study that. Okay. Then the secondary hyperparathyroidism, what's the cause of it? Some I mentioned here. I just want to point out that there is no role for surgery in this particular situation. Okay. Let's go to the next patient, second patient. Okay. This is slightly older lady, 59-year-old lady with a history of breast cancer post neoadjuvant chemotherapy, and had a routine PET scan was done, and that showed a lesion in the left lobe of thyroid gland, measuring about 1 centimeter. SU was mildly elevated, 5.6, and right lobe was normal. Gina, how will you take it? This is a patient with breast cancer, okay? And the PET scan showed this lesion. How will you move forward from here?
There is a PET uptake in the nodule of the left lobe of thyroid. First, we have to see the tirades of the lesion. So we have to go for ultrasound neck.
Okay, so let's see what the ultrasound. This is ultrasound scan of the patient. Okay, within the thyroid gland, there are about thyroid's 3 nodule of the left side, 2 of them, and along with that, there was a left superior lesion, which radiologically they suspect likely to be parathyroid lesion. The next step was a ultrasound guided FNAC of the thyroid nodule. That was Bethesda 3. How will you move forward from here, Dr. Samarth?
Sir, after ultrasonographical Bethesda 3 category, as it is Bethesda 3 category is a probably benign, sorry, thyroid 3 is a probably benign category, and Bethesda 3 is as AUS or FLUS of unknown significance. So we can follow it up for later. And there is one more superior parathyroid adenoma also on the left side.
Okay, how will you move forward? What will you do next? Dr. Samarth?
Sorry, sir?
What will you do next?
For superior parathyroid gland is enlarged, so we have to first confirm the hyperparathyroidism. Again, diagnosis of hyperparathyroidism will be a biochemical. So we have to do that biochemical test like serum calcium level, parathyroid hormone level, phosphate level, vitamin D3 levels.
Okay, calcium is 11.9, slightly higher than the last patient. PTH was 382. Vitamin D3 was within normal limit. Gina, how will you proceed?
This patient is having the serum calcium at a higher level, and parathormone is also elevated. Here, two things we can say. We can go for a differential diagnosis for this patient also. One thing, because serum parathormone is elevated and calcium is also elevated, it will be a primary hyperparathyroidism. Maybe because of the parathyroid carcinoma. Or we can, since the patient is a known case of...
Did you say parathyroid carcinoma?
No, sir, it may be a parathyroid adenoma or carcinoma.
Okay. How will you differentiate one from the other biochemically?
In parathyroid carcinoma, it will be abnormally high. The calcium may be more than 14 milligram per deciliter. But in parathyroid, it will not be to that extent.
Okay. So do you suspect carcinoma here?
In this parathyroid adenoma only.
Okay, good. Okay. And then go ahead. Yeah, please. Sorry, I interrupted your thoughts. Yeah.
And this we can go for parathyroid adenoma. Or one more point we can keep in mind that since the patient is a known case of CA breast and hypercalcemia is also there in this patient, we can also keep in mind about the hypercalcemia of the malignancy because of the metastasis.
Okay. So the treating doctor went for a sesame scan, and as you can see here, there's a left superior gland was localized. Dr. Samarth, how will you move forward from here?
Sir, again, sir, in this patient, as there is a single parathyroid adenoma is seen on both ultrasonography and on functional imaging studies, we have to move forward for minimal invasive parathyroidectomy, sir.
Gina, do you want any other investigation? How about 4D CT scan?
Since the calcium is
11 point something.
7.9.
Why did you ask for calcium? To decide the imaging?
So since two modalities are showing single lesion, no need to go for a third imaging, sir.
Fantastic, very good. Okay, no need for a 4D CT scan, is that right? Good. So the plan is, so this is a lady now, okay? Our lady is a previous history of breast carcinoma, a Bethesda 3 and thyroids 3, nodule of the left thyroid, as well as a possible superior parathyroid adenoma. How will you manage? Samarth?
Sir, for Bethesda 3 thyroid nodule, we can either do lobectomy or we can follow up these patients. And for superior parathyroid adenoma, we have to address that because there is hypercalcemia and increased parathyroid hormone levels. So we have to address the superior parathyroid adenoma in the form of parathyroidectomy.
Okay. Gina, would you agree?
This patient, we can alone go for parathyroidectomy also.
Yeah.
Because this Bethesda 3 lesion, we can keep in follow-up.
Okay. Anyhow, this, I'm not saying that this is right or not, okay. They did do a left hemithyroidectomy as well as superior parathyroid excision, okay. And Samarth, over to you, okay. PTH, the initial PTH was about 350. 10 minutes post excision is a 210.
Then, sir, if post-excision parathyroid hormone has not decreased, then again we have to check on the after 20 minutes also. And if still it is not decreasing, to more than 50% level, then we have to look for other sites of parathyroid tumors in the contralateral side or ipsilateral lower side also, because on functional imaging there are 10 to 20% chances that there will be any another adenoma present in the rest of the 3 glands. So we have to look for other glands also.
How will you do that?
Sir, we have to first see ipsilateral inferior parathyroid gland, whether we have to do a bilateral neck exploration, and we have to look for ectopic parathyroid glands also.
So Dr. Samarth wants a bilateral exploration. How will you proceed? This is your patient, you're operating, exposed, left parathyroid you took, isolate, removed, and thyroidectomy was done. But in your case, you would not have done a thyroidectomy, but PTH was 210. How will you proceed?
So this patient, we can go for intraoperative ultrasound to look for any abnormality, other lesion.
Okay. Okay, then let's say that we don't have access for intraoperative ultrasound. How will you proceed?
We can inject methylene blue and find out the staining of the gland.
Which gland? So you expose both sides or just one side?
Initially, we can expose the ipsilateral side and look for the methylene dye on the ipsilateral side. If it is not seen, or if we did not identify, then we have to go for a bilateral neck exploration.
Okay. Dr. Amit, any comments, questions?
Yeah, I don't think he's there, sir.
Okay. So this patient, we decided to explore the same site first. Okay, unilateral exposed, and there's an additional parathyroid, inferior parathyroid was identified, and PTH came down to 50. How will you proceed, Dr. Samarth? Will you go to
Sir, as there is a inferior parathyroid adenoma is present and we have removed and it is not within normal range, there is more than 50% drop in the parathyroid hormone levels. So now we can abandon the procedure. Sir.
Dr. Gina, would you agree?
Yes, sir, we can close.
Okay, let's stop it here. Any comments? Let's see, let me stop sharing and let's see what are the comments we have from the chat box.
So what I've done is I've put them on a slide, sir. So
Okay.
permission, I'll just beam it.
Yeah, sure.
Yeah.
You both did very well.
Thank you, sir.
Thank you, sir.
I think it's unfortunate that the internet woes of Amit sir continued, and I don't think he'll be able to do the expert talk as well. But let's do the Q&A here, and sir, you can take it from here. These are the 4 questions I found on the chat box here and on YouTube.
Okay, Gina, this was for your question. Let's ask Dr. Samarth.
Yes, sir.
We need to differentiate what is the definition of parathyroid carcinoma and adenoma. How will you differentiate?
Sir, usually parathyroid carcinoma will have abnormally high levels of calcium and abnormally high levels of parathyroid hormone, and this symptomatic complex will be severe in the form of parathyroid carcinoma. As far as the examination finding is concerned, that the patient usually can be presented with the mass in the neck, and usually this parathyroid carcinoma have aggressive local invasion in the surrounding structure. They can also present with hoarseness of voice also, and involvement of adjacent structures. Okay. And the symptomatic complex will be severe.
So Gina, yes, when you open up, it's totally different ball game, is that right? Have you seen any parathyroid carcinoma?
No, sir.
Okay, yeah, it's totally different. It's almost like an anaplastic type of lesion. It's adenoma is almost.
Parathyroid carcinoma, the size will be more than 3 centimeter, and the weight will be between 2 to 10 grams, and there will be local invasion to the thyroid, strap muscles, or trachea or esophagus. Local invasion will be there in parathyroid carcinoma.
Now, let's say they absent a frozen section. Okay. Can you differentiate a carcinoma from adenoma?
No, sir. Intraoperative frozen section, we cannot differentiate between them.
Very good. Excellent. Yeah. Okay.
Enlarged nodes, maybe.
So
Yeah.
the role is there when we want
You find some enlarged nodes also.
when we want to auto transplant or cryopreserve.
No. Samarth, the sir's comment was that you can have associate lymph nodes within the within the central compartment. Yeah. Go ahead. Samarth, go ahead.
So, sir, intraoperative frozen section usually help when we want to auto transplant or cryopreserve the gland to confirm whether we are doing it. What we are doing it is parathyroid gland is or not.
Okay. Gina, do you do routinely frozen section?
No, sir.
You don't. Okay. Yeah, I can see that. Yeah. Any other comments from any other faculty? Anybody else in the audience? I do that all the time.
So I invite our past president, Dr. Rajesh Toprani, sir, to kindly join in this Q&A, and we'll appreciate comments from him also.
Dr. Toprani, do you do frozen section for parathyroid exploration or adenoma excision?
I do. Yeah.
What's the reason? Because Gina seems to be quite comfortable with the PTH drop.
So, if you are very sure about your imaging and the system will be scanned that you are dealing with a single adenoma only, and doing a frozen section is probably quicker and more reliable. Because sometimes the drop in in my experience, what I have found is the drop in the PTH. Sometimes you have to wait for a longer time, then you have to repeat after 20 minutes again. It takes a longer time. So you can follow either way. I don't think it is wrong to do the surgery without a frozen section. If you have an access to intra PTH, you might well do that also. But
Okay.
I'm more comfortable with. I don't get many references for. It's a straightforward adenoma that I get a reference from a nephrologist or an endocrinologist, so it's easier for me. Unlike in an institute where Amit Agrawal is working, probably he might get some more complicated patients where he would face ectopic parathyroids or more of hyperplasias or secondary hyperparathyroidism.
Okay, Dr. Samarth, the third question. Let's say we have done the mini access, the lateral approach, and then the PTH was not dropping. Okay, how will you convoke? How will you explore the gland? Systematically go through ipsilateral side first. Is that right? So how
Yes,
will
sir.
you do that?
Sir, if one after remove one gland is not decreasing, then we have to the other ipsilateral gland, and we have to grossly examine
Incision. The problem, the question was, we made an incision at the back here. Okay. And then how will you explore? How will you extend? You do make a separate incision, or you extend the same incision?
So I'm not quite sure, sir.
Gina?
So we can extend the same incision towards median.
Okay. Yeah. Then the last question, patient with hyperparathyroidism and imaging showed a single function gland. Post-op pathology showed parathyroid hyperplasia. How will you proceed? Okay. And let me, Dr. Gina, how would you differentiate a hyperplasia from an adenoma post-op?
Based on the histopathologic features, sir.
Tell me, what are they?
In hyperplasia, there will be increase in the chief cells, oxyntic cells. Absolute number of cells will be increased. In adenoma, there will be histological features of a trabecular fibrous bands with trabecular network intersecting the tumor. The adenoma will be there.
Okay.
And there will be capsular invasion or vascular invasion and increased mitotic activity.
Rare. Samarth, size-wise, weight-wise, can you differentiate?
Size?
Yes, sir. Size will be more in adenoma, and they are usually more than 300 millimeter cube.
Milligrams?
Size.
Yeah, good. Let's see any other comments, questions.
Dr. Moni, what do you do in your practice regarding frozen section or inter PTA?
I am a very safe surgeon. I do all. I do. So what I do, I send the parathyroid to the pathologist, wait for close the wound, wait for PTH to come. I don't wait for once I'm localized, taken the gland out. It's fairly easy to pick up. Is all right, just for reassurance only. But I do both PTH as well as frozen section. But I would have closed the gland wound at that time. So by 20 minutes, I would have get both the results.
Is exploring the neck on the other side with if you put a focused lateral incision is quite difficult.
Very difficult.
So it's difficult. So you might consider putting a bigger incision in a skin crease somewhere else, a little bit higher up. Probably that would help you. Because if you use a very small lateral incision for a focused parathyroidectomy, you are going to struggle for exploring the contralateral neck.
Yeah, I totally agree with that. This is just a discussion, is all right? It's not. So if you make incision at the back here, and if you extend that all the way to other, especially women, that will come to the chest, to the sternum, get a hypertrophic scar. So leave it there, make a separate incision. So you assume once you decide that it's a difficult problem, we don't have to make it even more difficult by making struggling. You assume that it's going to be a difficult surgery, close it, and start as a fresh incision.
Thank you, sir.
Any other thoughts, comments? Dr. Rao, any comments, thoughts?
Yeah, so I think there's just one question left on the chat, which was related to differentiating parathyroid carcinoma from adenoma. But the question is, would functional imaging be useful, PET or something? Can you differentiate by the uptake value?
So we don't normally do PET scan, is that right? Only if you're saying parathyroid carcinoma, the calcium would have been very, very high, elevated. The PTH would have been very high. So you suspect, that's the time when you suspect. But most of the time we encounter when you open the infiltrative type of lesion we encounter. Then you cannot, so you have to, you cannot do a PET scan pre-operatively.
Yeah, so we don't do PET scan routinely for all patients, but if there is a very high calcium or very high parathermon, and the size of the lesion on imaging is more than 3 centimeters, you suspect, and you explore the neck with an anticipation that you might find something wrong other than a simple straightforward parathyroid adenoma. And it's usually a clinical on-table diagnosis when you find some infiltration in the surrounding tissue. It's usually a carcinoma, as Dr. Moni rightly said. It's quite, sometimes it is quite adherent to the surrounding structure, and you might find some suspicious lymph nodes also. That is the time when you do a radical dissection along with thyroidectomy and a central compartment rotation.
I think that finishes all the questions that we have on the chat box. I would like to thank both the examinees for their enthusiastic participation and really being very prompt with their answers. Thank you, Dr. Gina and Dr. Samath.
Thank you.
Yeah.
Both the examiners did well. Both the candidates did well.
Thank you, sir.
Thank you, sir.
Nice. I invite Dr. Sandeep Agarwal on behalf of the team of midterm ISO 2023 to kindly make his announcement. So.
Thank you, Sajan, for giving me this opportunity during the masterclass to invite all the ISO members as well as the surgical fraternity to join at Agra for the forthcoming. Am I audible?
Yes, sir.
I invite all the ISO members and the surgical fraternity to join for the mid-term conference in Agra. That is on 10th, 11th, and 12th of March. 10th is the workshop, which starts from 12 o'clock, in which we have an anastomotic workshop for the PGs, and 3 video workshops in the form of high-pack and PIPAC demonstration on breast oncoplasty, and a few video sessions for how I do it, kind of as demonstration for the PGs. There will be also 2 or 3 lectures on surgical oncology care in tier 2 and tier 3 cities, building up a surgical oncology in India, and resource development. The main conference starts on 11th and has interesting topics as well as participants during this meeting, and in which we are dealing with topics like medullary carcinoma, tips and tricks for esophagus and lung surgery, and panel and symposium, and practically all the specialties, including colorectal, lung, and esophagus. Then there will be a interesting topic on oligometastatic breast carcinoma management and minimizing breast treatment care in endometrial carcinoma. Besides the academic feast, we also have in the offering a lot of tourist attractions in and around Agra, including half-day excursions to the capital city of Fatehpur Sikri, Bharatpur, which is the bird sanctuary, and the temple city of Mathura. We have tourist attractions like Taj Mahal, Red Fort, Dayal Bagh, and Atmatwala in Agra. And the weather at this point of time will be pretty friendly, and that is why it was decided to have it in the second week of March. So I look forward for all the IASO fraternity to make it convenient to be in Agra in these dates, and we really look forward in welcoming.
This is an excellent opportunity for the youngsters to come and present posters as well as oral presentation. A lot of opportunities.
The abstract and poster presentation as submission date is still on, and I would request all the faculties there to stimulate their postgraduates to submit their abstracts fast.
Thank you, Dr. Sandeep Agarwal. This is the organizing secretary of Midterm IASO 2023. Now, the next segment of today's webinar was going to be the expert talk by Dr. Amit Agarwal, but unfortunately, the technical issues from his end are continuing. And so what I'll be doing is I'll be requesting him to record his expert talk. And what I'll do is I'll stitch that to this video here and upload it on YouTube. So to all the participants, please search IASO webinars on YouTube, and in a day or two, we should have the expert talk uploaded on YouTube as well. So lucky for some of us, there's a early opportunity for us to go back to work or family, and we'll call today's webinar closed at this point of time. I thank the Academic Council to give me the opportunity to deliver the word of thanks for today. I would like to thank our moderator, Dr. Moni Abraham Kuriakose, for spending so much time on preparing these wonderful case scenarios and being so lucid in his moderation for the session today. I personally learned a lot, and I'm sure everyone who was in the audience today and in future who's listening would really help from the session today. Thank you, sir. We would like to thank Dr. Amit Agarwal. We may not have seen him today, but I've been in touch with him and coordinating with him regarding today's webinar. He was very excited, and his expert talk itself, I have a copy of it with me here. It's more than 150 megabytes in size. So I know how much he had worked for it, and I'm sure that we'll see it on YouTube and see what his take on the management of parathyroid tumors is as well. And I thank him for that effort. We would like to thank IASO President Dr. P.K. Das and Honorary Secretary Dr. Chandramohan to continue supporting our program. We would like to thank the zonal advisors, Dr. Raj Govind Sharma sir, Dr. Sanjeev Sharma, Dr. Arnab Gupta, and Dr. Sadasivam for their advice, because this program runs like an engine every 2 weeks only because of the excellent help and advice that we get from all of them. We would also like to thank our immediate past president, Dr. Toprani sir, who was a guiding force for us in continuing the program from season 1 to season 2, and is still someone whom we reach to whenever we are in a pickle. Thank you, sir, for your constant support. With that, I would like to close the webinar for tonight. Thank you, everyone, for logging in. We will see you next.
Special thanks to Dr. Moni for agreeing to be here.
Yeah.
Thank you, sir. Thank you.
Thank you, sir.
Thank you. Good night.
Good night.
Yeah. Good night, everyone. We'll see you next at IASO midterm at Agra.